Welcome to another episode of the Core Consult RX podcast. Cole, AJ, what is going on, gentlemen?
Got the whole crew today.
Yes.
I'm excited.
Back at it. Last time, if you guys haven't heard our Prevagen episode, me and AJ just sort of ranted about the OTC supplement the whole time and didn't do an actual episode per se. So that was fun, change of pace. But we're going to get a little bit more back on track today because this episode is once again ACPE-Accredited for 1 hour of continuing education for pharmacists and nurses, thanks to our partnership with freece.com. And so if you are a Free CE Unlimited member, then after the episode, go to the link in the show notes that will take you to their website, and then you'll see a area where it'll ask for a password to access the post-activity test, and you will use the password BLOOD in all caps. That will give you access to the quiz questions. There's only 10 of them. Knock those out, and you'll get your hour of credit. If you're not an unlimited member with freece.com, we highly encourage you to check out their abundance of different learning opportunities. They have monographs, they have live CEs, they have podcasts, like, us, and
Podcast, singular.
Yeah, singular podcast. Well, for now anyway, until they find a much better option than that. And you can also use a promo code that we have in the show notes that will give you a discount on the annual cost of the unlimited membership. So definitely check that out. There's a lot of good stuff, and as always, we appreciate them working with us and being able to offer this service.
It's a violent password.
Blood.
Blood.
Why is it blood, Cole? What are we talking about today?
Well, we're talking about anticoagulation.
Yes.
Which we're going to try to hit a lot of different stuff. So anticoagulation is a dense topic. There's a lot of different disease states and conditions related to it. So we're more going to focus in on kind of drug by drug anticoagulant and then branch off within that into the disease states that it covers, right?
Mm-hmm.
Yeah. First thing I want to point out is a little bit of terminology. So there's a few different terms for anticoagulant, anti-thrombotic agent. So an anti-thrombotic agent would be both antiplatelets, right? So aspirin and clopidogrel, when we're talking about dual anti-platelet therapy, those are antiplatelets, but it also includes anticoagulants. So we're going to be focusing on anticoagulants today, which primarily the ones that act on thrombin and factor Xa in the clotting cascade. Thrombin is important. It's the final enzyme of the clotting cascade that produces fibrin. It's formed by the proteolytic cleavage of prothrombin by factor Xa. So we're going to talk about drugs that are direct thrombin inhibitors. And then there's factor Xa, which acts, like I said, immediately upstream of thrombin in the clotting cascade. It's at the convergence point of the intrinsic and extrinsic coagulation pathways, and it's formed by the proteolytic cleavage of factor X by an enzyme there, which are made up of other procoagulant factors. And we're going to talk about factor Xa inhibitors as well and what they can be used to treat.
Yeah, and I think that's a good way of looking at it too, because like a lot of these, obviously the clotting cascade, you'll see some common targets of our drug therapy. So our factor Xa inhibitors, also like our direct thrombin inhibitors, and we'll also get into some agents, or an agent in particular that all of you, I'm sure, are very familiar with, but a vitamin K antagonist, which known as Warfarin, we'll go through some of the clotting factors that are vitamin K dependent, and we'll kind of go through that because sometimes it's easy to overlook like the true mechanism of that. So I think that's an important one to kind of go back through just so we have a good solid background, context of the mechanism of action for that, since it's so commonly used still to this day, even though there's some potentially better options. But
right.
we're going to
depending
kind of
on the situation.
Yeah, and I think that's the thing that like Cole was saying, it's hard to like really come up with a good, other than breaking down like, atrial fibrillation or VTE specifically, and like coming up with a very specific disease state that we're covering. It's hard to kind of just lump anticoagulants all together. So what we'll try to do is just kind of touch on a lot of the key points in some of the uses, for like Cole said, for individual agents. But this will not be completely all encompassing every disease state. We'll just really want to get into more of the actual, I guess, pharmacology of these and how they're utilized and whatnot.
Right.
All right. So, what do you want to start off with, man? Anything in particular you want to?
You want to talk a little bit about VTE first?
Sure. Yeah. Since we just said we're not going to get specific.
I know. Yeah. Then I was like, well, we did talk about VTE. So
yeah. So I think in VTE and this, depending on the agent we're using, as well as like comparatively to like atrial fibrillation, and then we can even go further like non-valvular AFib versus valvular. You're going to be using different options, but when you hear the term VTE, it's basically like the umbrella term for either a deep vein thrombosis, which is where the clot is formed, and it's kind of stationary. It's not embolizing, so to speak, and then once that clot becomes dislodged and starts to become mobile in the body, that's when it can turn into a pulmonary embolism, which can become fatal within minutes in some cases. And the DVT, as long as it's stationary and stays a DVT, is usually not fatal. But we still want to cure it because we do not, and take care of that clot because we don't want it to become PE.
Right.
So VTE, venous thromboembolism, is basically the umbrella term for both of those things. So we'd want to be specific if we were mentioning which type it was. But since a lot of times the treatment and the duration of treatment tends to be kind of the same in some of those cases, then we kind of lump them all together under that term.
And there's a lot of risk factors related to VTE. We won't get into all of them. You're probably familiar with some of them: trauma, obesity, age. But they kind of fall into three distinct factors known as Virchow's triad, which would be blood stasis, vascular injury, and hypercoagulability, all increasing your risk for VTE.
And then the other thing with anticoagulants that you'll often see, especially if you're in primary care, but especially if you do anything with cardiology or anything like that, patients that have atrial fibrillation, we always think of the medications to actually reduce the risk of going from normal sinus rhythm back into AFib, or keeping the patient in control as well we can from a rhythm or rate standpoint. But the patients that have atrial fibrillation, especially when they're actively in AFib, the blood can pool in that left atrial appendage, which can then form a clot, and then they can kick that clot out, which can cause an increased risk of stroke and whatnot. So anticoagulants do play a very big role with AFib as well.
Yep.
So when we go through these, the other thing, which I think we did a podcast on this not too long ago, but like acute coronary syndrome, when we're talking about, a patient that's having a STEMI or NSTEMI, unstable angina, we need to go in there and do a PCI and actually place a stent. The anticoagulants are also an important role in that process as well, because we want to, as well as antiplatelets, but we'll mention a couple of those that are somewhat preferred in most cases for those types of interventions. We'll go through the different agents and we'll mention the disease states again that we typically see these in, but we'll go through a lot of the pharmacology, like I said.
Right. So I guess we can start with the direct thrombin inhibitors then. Do you want to do that first?
Sure, yeah.
Okay. So there are parenteral direct thrombin inhibitors. They are bivalrudin and argatroban. They directly block thrombin, as you'd imagine from the name. There was an older one that's no longer on the market called lapuridine, and then also deciridine, also not on the market. So the only two that you're going to see are bivalrudin and argatroban. So bivalrudin is a 20 amino acid peptide. It binds to the thrombin catalytic site and exosite 1. It reversibly inhibits thrombin enzymatic activity. So one of the things you'll hear us coming back to with a lot of these anticoagulants are whether it has the ability to have an antidote and to be reversed. When we talk about the vitamin K antagonist, when we talk about dabigatran and the DOACs, whether or not they have one, you'll hear that come up. So you're going to see these primarily inpatient in the hospital. So the indications for bivalirudin would be frequently patients undergoing a PCI, a percutaneous coronary intervention, and it's also okay to use in HIT, heparin-induced thrombocytopenia. And we'll touch on that in a minute. And then argatroban is very similar as far as what it can be used for. It can be used for HIT as well as a PCI, and another direct thrombin inhibitor, parenteral, not oral.
Yeah, and I think the bivalirudin, I think especially, is the one that you'll oftentimes see, given during an acute coronary syndrome where the patient, like Cole said, is undergoing a PCI, so they're on the way to the cath lab. That's sometimes they're started on something like enoxaparin or low molecular weight heparin, but once it's kind of decided that they do need to get that percutaneous intervention in the stent place, that they will oftentimes be switched over to bivalirudin, and that sort of stems from some older studies that showed some superiority with bivalirudin compared to heparin or low molecular weight heparin. I will say, though, that there is some data now that shows that might not be as quite important as we thought, or as quite as beneficial, I should say, as we once thought. However, I feel like some of the inpatient providers that I talk with, and some of the hospitalists and things, have said that they all still utilize bivalirudin in the setting of a PCI. But the study I'm thinking of was specifically done in patients that were experiencing a STEMI. It was called the HEAT PPCI trial, if you want to take a look at that. But it was basically saying that bivalirudin might not offer better efficacy or safety necessarily compared to unfractionated heparin. But it's one of those things that, again, just from historically, we did see the benefit. That you'll probably oftentimes still see that used.
Right. And the alternative is heparin, low molecular weight heparin.
And just for some dose adjustments, some things to be aware of, argatroban, which, again, injectable direct thrombin inhibitor you'll see sometimes in the inpatient setting, not only in PCI, but if they need an anticoagulation on board and they have had a history of HIT or something along those lines, they may use this one in, just as a routine. I know when I did a rotation at East Cooper Hospital, this was like their go-to anticoagulant if they weren't going to use enoxaparin. But it does have dose adjustments that are required if the patient has hepatic impairment. So, if the patient has especially unstable hepatic disease, if their Child-Pugh score is B or C, then you do need to make some dose adjustments there. Bivalirudin is something we have to dose adjust based on the creatinine clearance. So once it falls below 30, then we would look for a dose decrease for that agent.
Right. As far as monitoring in a PCI, it's done by the activated clotting time for argatroban. If you're using argatroban in HIT, you would get an APTT at baseline, and it should be obtained prior to administration and then repeated 2 hours after starting therapy.
There you go.
What about oral direct thrombin inhibitors?
Yeah, so the oral direct thrombin inhibitor, the one that our minds tend to go to is our buddy dabigatran, which it gets lumped in with the factor 10 inhibitors, also known as like the DOACs, or used to be called the NOACs, right? The novel oral anticoagulants.
There's also Tasoacs. Have you seen that one?
No.
I think, don't quote me, but I think it was target selective oral anticoagulant. And then there was...
Yeah. I think I have seen that now that you say that.
NOAC could mean novel, newer, or non-vitamin K. All NOAC apparently stood for all those things.
That one's a bit of a stretch.
It's kind of a stretch.
The third one's a stretch.
It's a stretch.
Basically the dabigatran, was the first of the oral, new anticoagulants on the market, the DOACs, as I prefer to call them.
Yeah, not so new anymore.
But it is, definitely not now. And it's one of those things that it's now been often replaced by technically the newer DOACs and the actual factor 10 inhibitors.
The new.
Exactly. There you go. But it was out there initially on, and it's a true direct thrombin inhibitor as opposed to affecting factor 10. But just to kind of go through a couple things with it, the half-life that was used or has been reported with this drug is around 12 to 17 hours. So it is dosed twice a day, which, can, especially in a patient who has to take this long-term, can be, not ideal. The other thing that's kind of unique about this one is it is very susceptible to moisture in the air, and so it comes in a special bottle with a desiccant or in these blister packs, and it's supposed to obviously keep the product from being in contact with moisture and losing its potency. And so the patient had to be given this medication and had to be dispensed in the original container, and then they had to be told to make sure that they don't actually empty these into like a pill box or anything like that, because depending on where they keep it in their house or where they are located, geographically, they may have more issues with humidity and whatnot. It can actually greatly decrease the efficacy of the dabigatran.
Right, significantly. And this is important because frequently in the pharmacy, this one would very easily just get popped open without realizing that it has to be dispensed in its original container. After it's open, it just has to be used within 4 months. So it's not like it means that you wouldn't be able to use it, but it is supposed to be dispensed in its original container for the bioavailability. So interestingly, there was a time not too long ago where there was concern that clinicians were having trouble with the DOACs as far as dosing and using the appropriate doses for the appropriate indication. They actually did some studies and found that a large proportion of the prescriptions weren't the correct dose for the indication. So they mentioned specifically with dabigatran to make sure you're not underdosing. So I'll mention a couple of the doses for VTE primary prophylaxis in surgical patients. It's 110 milligrams 1 to 4 hours after surgery, followed by 220 milligrams once a day for 28 to 35 days, specifically for a hip replacement, or 10 days for a knee replacement. If you're treating and for secondary prevention of a VTE, it's 150 milligrams twice a day for 5 to 10 days. 150 milligrams twice daily after 5 to 10 days of parenteral anticoagulation. Adequate treatment for VTE is full dose anticoagulation for 3 to 6 months. And then this one can also be used for Afib, right? So stroke prevention and Afib, 110 milligrams twice a day, or 150 milligrams twice a day with creatinine clearance greater than 30. And interestingly, for a lot of the ones we're going to talk about, there's different dose labeling in Europe. So for our friends across the pond, you're probably going to see different doses for that.
Yeah, that's a good point, actually, because we do have a lot of international listeners, believe it or not.
Right.
And so, that's a good point to make. The other thing that's kind of unique about this one, and this came directly from the studies that we're looking at, this being utilized in Afib patients. So patients, when they were comparing this to Warfarin, so this was, again, for stroke prevention and Afib, they were looking at not only the efficacy, but also the risk profile from like a bleed standpoint and other just random adverse effects. And so compared to Warfarin directly, it did seem to be that this one might be a little bit more efficacious as far as the overall outcomes and reducing the risk of like a stroke and whatnot, but it did seem to increase the risk of like a GI bleed potentially more so than Warfarin. And so it's something that because some of the data with, especially in Afib specifically with some of the other agents, is a little bit more impressive. That's kind of why this fell out of favor somewhat. The other thing that's kind of important, if you look at like the recommendations, at least how the drug was studied initially, when we think about like starting like Warfarin, and we'll get into this in a little bit if is the why, but we often bridge with a low molecular weight heparin or an unfractionated heparin to avoid like a hypercoagulable state, which makes sense with Warfarin. We'll explain why when we get there. But with a DOAC, that really doesn't make a lot of sense. But this one initially was studied with that bridge therapy. So the initial like package insert recommended bridge therapy with dabigatran, and specifically because that's how it was studied.
Right.
I don't know of anyone who actually does that
Right.
in practice. So just to kind of throw that out there, because it really didn't make sense. You're technically anticoagulated pretty quickly after taking, the starting dose.
Right.
The other big common side effect that people complain about this one in particular is dyspepsia. It's very common, up to 33%, and some studies have showed that dyspepsia can happen. So, patients that have, issues with reflux and things of that nature, we got to be cautious with this one. And again, this one's not utilized nearly as often as it used to be. Its initial claim to fame when it first started to fall out of favor was that it had a reversal agent. It was like one of the first of the DOACs to have a reversal agent. And since it's different than the factor 10 inhibitors, it had a unique reversal agent that wouldn't work on the other agents. So the brand name for that was Praxbind. And
Usizumab or something.
Yeah. And it was something that that was its go-to as far as at least the other ones, if you start bleeding, there's nothing we can do, which is not quite true. But now that those also have the reversal agent, they can't quite use that,
which turns out to be a bigger deal than maybe it was portrayed to me. Like when I was in school, like we were kind of taught that Warfarin's got a reversal agent and Dabigatran had just come out, but they didn't really harp on it too much. But I've come to find that it's kind of a big deal to have a way to
reverse it,
other
than just giving blood.
Right, other than giving blood or activated charcoal for what's in your stomach or something like that.
Yeah.
So the RELY trial, which was a big trial with Dabigatran versus Warfarin and Afib, found that non-bleeding GI events, so Mike mentioned dyspepsia, also dysmotility, and reflux were twice as common with Dabigatran than Warfarin. So that definitely is a significant side effect of it.
Yeah. So that's Dabigatran, but we also have our DOACs, which would be apixaban, we have edoxaban, and we have rivaroxaban. Those three are also utilized for both the treatment of VTE as well as stroke prevention and Afib patients. And they're for non-valvular Afib, they're usually preferred over Warfarin. If you look at the guidelines from most recently in the U.S. anyway. There's also an agent called Bitrixaban, which is utilized for prophylaxis of DVT in a patient who has an extended hospital stay, but you would not use that one in the same capacity that you would the other DOACs. So It's in the same class, but it is a different agent.
One positive thing of DOACs as we go through, we'll obviously get into it, but I just want to mention off the top is lesser drug interactions compared to Warfarin. Warfarin has all sorts of them, but it's not drug interaction free, which I don't know, was kind of my perception for a while. I would think of rivaroxaban as having 3-4 interactions, but there is something relatively new that found an increased bleed risk with apixaban along with systemic fluconazole, and they think that's related to the 3-4 interaction. It's only systemic, it's not topical fluconazole, but they found that there was a 3.5-fold increased risk of bleeding with patients taking that combination compared to when they were receiving apixaban Eliquis without fluconazole. And they did not see that increased risk with the other DOACs either. So we'll talk about some of the studies. We generally think of Eliquis as being very low bleed risk compared to the others, but this specific instance is just in the last few months this came out.
Yeah, that's it. I think it was like May of this year, right? That warning was put out.
Yeah.
The other thing is the doses can all vary amongst these agents, and depending on what treatment you're or which disease state you're actually utilizing these in, whether it be VTE or Afib or even now rivaroxaban. You may see some of the really low doses, like for example the 2.5 milligrams. You may see that floating around. That's not just because we're trying to lower or using low doses in these other disease states that it was originally approved for, but they actually have an indication now at 2.5 milligrams of rivaroxaban twice a day for peripheral arterial disease, specifically in patients that have diabetes. So
interesting.
That is some of the newer data, newer approvals for that particular medication, but that has doses all over the place. And each one of them has their own specific dose adjustments based on either renal function for some. It can also be, a combination of things like with the Eliquis. And the one that I always always stands out to me is the edoxaban, which I feel like that's one I never really see anyway. But that's a pretty unique agent in the fact that its dose or its renal dose adjustment is actually complete backwards from what we would typically think. So it has a dose adjustment to where if the creatinine clearance is above 95, so your creatinine clearance is too good, basically, you can't use this medication. It's basically just not filtered out appropriately and or reduced. I'm sorry, it's filtered out too quickly rather, and it's gotten rid of. And also if the creatinine clearance is less than 15, you also can't use it because then it builds up to too high of an extent.
You know what's confusing to me about that?
Tell me.
Is that edoxaban is the least by a percentage renally excreted of the four. I'm gonna have to find the table again, but I think it was 25%. But then as you looked at the other ones, they were all a higher percentage renally excreted. I'm confused by that, but I guess that's just a specific thing with edoxaban. I'd love an answer to why that is.
Yeah, but I mean that's literally like in the package. It's just bizarre. I can't think of a single other drug that's the case. Can you?
No.
Sorry, sir. Your kidneys work too well.
Yeah. Sorry, sir. You are too healthy for this drug.
So yeah, that's just one of those things that is unique to that. The other thing with rivaroxaban, I mentioned like now that it's got these lower doses floating around, specifically when you get to 15 milligrams and up, so 15 and 20 milligrams basically, it does need to be taken with a meal because that will, at that point, it affects the absorption. It's not, food doesn't affect the absorption at the lower doses, but once you get higher, it actually becomes a much bigger role.
Right.
So it's once a day treatment, usually for like in Afib patients, but it's taken with or after a meal. And so that's not as big of a deal with the PAD indications and whatnot, but just to kind of be aware there is a difference there.
And that's the only one that has that indication. So they're all pretty similar as far as efficacy. There are some subtle differences, and there's some subtle differences as far as safety goes with different disease states. As far as differences between them, apixaban, similar to dabigatran, is given twice daily. Rivaroxaban and edoxaban are both once daily, so that's a positive thing if you had a patient who might have an issue with that. As far as their efficacy goes, there was a retrospective review of like 37,000 patients with VTE prescribed either apixaban or rivaroxaban for the first time, and the risk of recurrence using some special score that they use was lower with apixaban than rivaroxaban. There were about 11.4 fewer events per 100 person years with apixaban. So that's not a strong level of evidence, but if you're looking for something to guide, that is an interesting study in apixaban's favor.
Yeah, I think the other thing to consider too is their use in patients that are obese, because the guidelines haven't really given us like a set difference, I would say, but they definitely
they don't
some
give
guidance.
Any dose. Yeah.
And so as far as because the initial concern was that if a patient has a BMI 30 or greater, that they would lose their efficacy. So if you look at some of the older studies, like the pharmacokinetic studies, it looked like there was about a 30% decrease in, and this is for apixaban specifically, just to give you an example, but a 30% decrease in the Cmax and 20% decrease in area under the curve when a patient was 120 kilograms or more. Now, that being said, specifically like in patients with non-valvular atrial fibrillation, they've done some sub analysis from the randomized controlled trials, and they showed that the enrolling patients basically receiving apixaban showed less major bleeding in patients that were greater than 120 kilograms compared to the lower weight patients. So in that case, it may actually have been somewhat of a good thing, but it doesn't seem to actually lower the efficacy in some of at least the limited knowledge that we have. So I think in that particular case, or a lot of these, agents that are newer, until we have definitive data, you're still going to want to use some caution, but it's something that a lot of times the data is shown, even in patients with BMI over 40, that there's not necessarily a dose adjustment necessary. So just something to keep in mind. It's still, they're still looking into it, and something that they need to, consider and weigh
Right.
out when you're looking at options, and it may come up on rounds or what have you. But there is at least some data to back up using this in overweight patients, obese patients.
Right. As far as some other differences, edoxaban in VTE, don't you have to use a parenteral agent first before getting into the edoxaban dosing?
Edoxaban. Well, so that's the same thing. They basically studied
Just
it
the way
that
they
way,
studied, yeah.
so they have to include that. But I don't know of anybody that actually does that clinical.
Gotcha.
Or I don't know anybody that uses edoxaban anyway. So I should also preface it with that.
Right.
But I'm pretty sure that's just because they set the study up that way.
In VTE, rivaroxaban and edoxaban also have kind of a loading dose, a higher dose before you get into the maintenance dosing.
Yes.
As far as bleed risk goes, so there was one study, it was about 5,000 patients. It was also retrospective, looking at rivaroxaban and edoxaban, ultimately finding that rivaroxaban may have a slightly higher bleed risk, mainly bleeds in the lower GI tract. So neither of them were extremely significant. It was like 3.2 versus 2.5 bleeds per 100 person years. But again, if you're looking for something to direct you, they think it was related actually to the higher peak concentrations from the once daily dosing of rivaroxaban versus the twice daily of apixaban. So interestingly, a negative about the once daily dosing of rivaroxaban, but that's just a theory.
Yeah. So these are definitely the go-to options for a lot of different things now, and you'll see these a lot more than they were previously. But definitely something to be aware of as far as those warnings and concerns.
Right.
Anything else with those in particular?
No, we could circle back to them with a little extra near the end if we need to, but you want to talk about Warfarin
Yeah, I want to
next?
make sure we get all these in. So Warfarin. So this drug is something, like I said, I'm pretty sure a lot of you are familiar with, but it's pretty unique as far as its mechanism of action. So I feel like because of the diet restrictions, or at least diet stability, I should say, that you need to have with this when it comes to vitamin K intake. Sometimes people assume that it's just straight up blocking vitamin K, and then that's just how the mechanism is working, which isn't actually the case. And so if we think about like the actual mechanism, or let's say even take it back further, let's talk about vitamin K in general. So the reduced form of vitamin K is utilized as part of the activation process for the clotting factors 2, 7, 9, and 10 specifically. And so we don't really store a lot of vitamin K in the body. And so a lot of it's coming directly from our diet. And so the vitamin K in its reduced form is utilized as like sort of like a cofactor for that activation of those 4 clotting factors that are vitamin K dependent. And its byproduct is actually obviously the oxidized form of vitamin K, which again, we don't really store true vitamin K. So in order to not just let that go to waste, we have the enzyme vitamin K oxide reductase, or even better, epoxide reductase, because it actually forms like this epoxide vitamin K. And that enzyme is what you'll see it abbreviated as VCOR. But that enzyme is actually what recycles the vitamin K back into its reduced form, that it can be utilized again as a cofactor for that reaction. Warfarin actually blocks that particular enzyme. And so if you have, a steady concentration of intake, from the diet perspective of vitamin K, once you get the patient's level stable, as long as they stay consistent with that vitamin K intake, you'll keep them in the range, specifically using the INR that we want them to be in. INR being if the lower the INR, the more coagulable they are, and the higher it is, the more anticoagulable they are. Sorry for the dogs barking. And that will and basically increase the bleed risk if it goes higher. So that being said, if you start taking in more green leafy vegetables or other like vitamin K rich foods, basically you are introducing more vitamin K, which allows for more clotting to happen before the warfarin can actually get to that new concentration of vitamin K and shut off that enzyme. So it's like it's starting it prior to the vitamin K and the oxide reductase enzyme playing a role. It's hard to say that without seeing a graph. I feel like, or not a graph, but a picture.
I think you explained it perfectly.
Oh, thank you, Cole. AJ, do you concur?
Sounds good.
Okay, thanks.
Did you follow along, AJ? We're gonna quiz.
I did.
We're gonna quiz you afterwards.
He's playing on Instagram. But yeah, so and then vice versa. Obviously, we also don't want to just go and stop. You don't want to go to the carnivore diet all of a sudden if you've been eating a lot of green leafy vegetables and just take away all your vitamin K, because now that's going to cause a new problem.
It's a new one for me, the carnivore diet.
You even heard of that?
No.
People just eat straight meat. Like,
What?
Yeah,
I did it.
Did you?
What?
It
Yeah.
was pitiful.
It's terrible.
It was not fun?
Me and AJ tried it for a week one time just to be funny. Remember that?
I lost a lot of weight. I did.
It really does make you lose weight, except it'll destroy your GI tract.
You don't eat carbs because you're eating meat all the time.
Meat.
So no carbs.
Yeah.
That's probably what makes you lose the weight, right?
Yeah, I would have.
So what would be wrong with meat and vegetables?
Because it's, meatheads that came up with it. I don't know.
It doesn't make any sense.
It's stupid, but you've seen that guy like Liver King on like social media and stuff.
Oh, sure have.
He's a big advocate
More
for
primals.
Yeah, it's so annoying.
For the carnivore diet?
Yeah, but it's the same kind of.
Yeah, but he's a little like.
He's over the top.
He's nuts, huh?
He also says he doesn't do steroids, which we knows, which you know is a lie. But it's one of those things that he's like, a vegetable, I would never. Like,
He also doesn't he sleep on I don't know.
Probably. He's a weird dude.
He doesn't sleep on a bed. He sleeps on uncomfortable things.
Yeah, of course. Because why wouldn't you?
I know.
That's so dumb. I prefer my bed.
I like my bed.
Yeah. Anyways.
Yeah. So
shout out Liver King.
So a little more about warfarin and vitamin K antagonists. So they're challenging because they have a narrow therapeutic window, right? Their therapeutic range is narrow and their dosing is affected by many factors, diet like Mike was talking about, also drug interactions, even genetic variations. So we have some advantages and disadvantages that Mike kind of mentioned. Disadvantages would be there's generally seems to be higher rates of thromboembolic events and bleeding complications associated with warfarin in patients with Afib. There is, like we all know, the requirement for frequent monitoring of INR, which you don't have to do with the DOACs, though that can be a two-edged sword. I don't think that's the right analogy, but it might be a good thing, right? So with the DOACs, while we don't have to do the monitoring there's monitoring to be done, but not constant monitoring like INR. There's no consistent way to make sure that the patient is adherent and in a anticoagulable state.
Yeah.
Whereas with warfarin, even though there's an annoying monitoring to be done, we can know that they're safe and they're taking their medication.
Yeah. Just to piggyback off that really quick, because that always gets confused. Cause when I'm talking to my PA students and whatnot, I'll say if adherence is something you're worried about, then maybe warfarin would be a better option, which sounds totally backwards because you're from the monitoring standpoint. But I always think about this one patient that we saw when I was in school still, and I did a rotation with the stroke team, and the patient had come to South Carolina on vacation and had AFib, and they were taking one of the DOACs stroke prevention, and forgot their medication at home and they were like, I'm only going to be here for a few days. Who cares? Didn't take it. Dropped dead from having a stroke on the beach. God. 2 days into the vacation, because within missing one dose, 2 doses, you're already going to be back in that hypercoagulable, or not even hyper, but just regular coagulable state, and that risk comes right back. So
and there's warnings on there for increased risk
to not stop them. Thromboembolic
events if with abrupt discontinuation.
Yeah, so that's the big thing. Is just because there's no monitoring doesn't mean that the adherence isn't super important.
Right. You might even see a recommendation, which I've seen, where if you have a patient on warfarin, if you're considering who might be a candidate for one drug over another, and you have a patient on warfarin who's really good about following up with their INR visits, you might think, oh, that's good for warfarin. It's a good guy for warfarin because he's good at following up. But that actually, you could argue, well, he's adherent with his visits, which means that he's probably going to be adherent with a DOAC too, whereas somebody who was inconsistent with their INR follow-ups, the first reaction might be, we need to get him on a DOAC because he's having trouble following up about the warfarin. But really that might mean, no, it might be more dangerous because he might not be reliable to take his medicine.
Right.
Very interesting way to look at things, but it's kind of backwards, but it makes sense when you
think about it.
When you look at it in a mirror.
Yes.
Okay. So there's also there's a cost burden associated with the visits for INR and a time commitment. But then there's a bit more of a cost burden from just a straight drug standpoint from the DOACs. Not as much of an issue these days with if you're insured. If you're uninsured, that's different, generally speaking, unless you have access to lower cost drugs and things like that, subsidized drugs. With warfarin, the dosing is affected by illness, changes in diet, all the drug interactions. Advantages of warfarin might be it's been used for a long time, large body of clinical evidence to support its use, and the clinicians who've been practicing for a while are familiar with it. We mentioned the studies looking at inaccurate dosing with the DOACs. There's greater efficacy than other anticoagulants in prosthetic heart valves. So mechanical heart valves, that sort of thing, you don't use the DOACs, you only use warfarin. It's low cost, it's widely available. It's very easily reversed, and we have very good data on that and how to do that. There's the ability to increase the intensity of the anticoagulation when appropriate if the monitoring says that you need to do that, all those sorts of things. So there's a lot of different things you want to consider when looking at warfarin versus one of the others.
The other thing with warfarin, I guess this is a good, when we'll come back, I guess, to talking about INR and like reversals of this, since there's some nuances to that as well. But when you're treating a patient specifically for VTE, you'll always hear people talk about bridging therapy, which can get kind of confusing. I feel like if you don't think about it initially, because it's like, well, why do we need to bridge? Because basically what we're trying to avoid is warfarin puts the patient in a hypercoagulable state initially, which sounds like how the heck would that happen when it's an anticoagulant? But we already mentioned some of the clotting factors that are vitamin K dependent. We actually have some of our our natural anticoagulants that are also vitamin K dependent. So some of the more common and our natural anticoagulants that we always think about, protein C, protein S, those are also going to be dependent on vitamin K as well. And they also have shorter half-lives than the clotting factors do. So when you first start a patient on warfarin, those natural anticoagulants actually are the first to go away as far as their availability, and the person is pushed into like a hypercoagulable state initially. So bridging with enoxaparin, low molecular weight heparin, is a good way to instantly keep the patient anticoagulated until the patient's INR becomes stable. Usually 2 to 3 is what we're shooting for in most disease states. Sometimes you'll see 2.5 to 3.5 for like certain like high risk indications like mechanical mitral valves or 2 mechanical heart valves, things like that. But oftentimes 2 to 3 is usually the range we're looking for. And so the thought is, while we are waiting for that INR to stabilize, we give bridge therapy. Usually we do 5 days of therapy or until they are therapeutic. They've reached the therapeutic INR, so which could be, but at least 5 days. So it could usually be longer than, or not usually, but it could be longer than that. So if you check it, after 5 days and they're a 1.7, then probably do another day or two of the bridge therapy until they're in that therapeutic range. Right. But that's the reasoning behind it. Now, this is not the case for Afib. They used to bridge for Afib as well, but they kind of have done away with that because the patient doesn't have an active clot. But when it comes to VTE, the bridge therapy is absolutely important.
Yep, for sure. There is some baseline monitoring that you want to do for warfarin. So we obviously have the INR, like Mike talked about. But at baseline, get a prothrombin time along with the INR and baseline activated partial thromboplastin time, APTT. Also get a CBC, serum creatinine to check the GFR, liver function tests. You may be able to identify some potential alterations in warfarin metabolism if somebody has an issue. And then you don't want to use it in patients who are pregnant. So if they're of childbearing potential, you might want to confirm that as well.
Usually we use low molecular weight heparin or unfractionated heparin in pregnant patients.
Yes.
So the other thing is with warfarin too, if you guys have ever worked in a dispensing pharmacy, you notice there's quite a few strengths available. It comes in 1, 2, 3, 4, 5, 6 milligrams. I can't remember all the different doses, but there's a lot. So why is that? Or you may have noticed that there's some weird regimens people will be put on sometimes where the patient will be on 5 milligrams Monday through Friday and then 2 milligrams on Saturday and Sunday. It's one of those things that with warfarin, when we have to change the dosing and make dose adjustments based on the patient's INR, we base it off of the total weekly dose of warfarin. So you would, let's say the patient's on 5 milligrams every day. We would take that and look at, we'd start with the 35 milligrams per week, and that's what we would make, our doses, a 10 to 15% dose change based on that week. And then we would spread out the, how we can separate that out from a day-to-day standpoint. And if it doesn't quite work out, then maybe we have to use 2 different doses on different days. So it can get kind of confusing, but that's where that's coming from, is basically the fact that you're going off the week dosing, not the individual day dosing.
It can get confusing. And so to me, that's a negative, the confusing dosing, especially because it's going to be changing. It may be changing frequently if you can't get a consistent INR. So to me, that's a mark in the DOAC favor, but also it's still only going to be once a day. So versus a patient who might have an issue with a twice a day DOAC, if that's the one that, for whatever reason, the only one they would have access to is one of the twice a day ones, warfarin might be better in that instance. So Mike mentioned 5 milligrams a day, 35 milligrams a week. That's probably generally the most common starting dose, and then monitor INR and adjust from there. For a patient who's frail, older, 70 to 80 years old, maybe they're malnourished or they have a kidney or liver disease, when you pull their labs, you might, or they're on a drug that interacts, right? Like amiodarone or all sorts of other drugs that interacts. That might raise the level. You may start with a lower dose, like 2.5 a day or 2.5 alternating with 5, which would be like, what would that be? Like 27.5 or something a week if you're looking at the weekly dose. So yeah, you do have to consider those factors before you start.
I had a patient one time who I was seeing for diabetes, I think, but was on warfarin. And I just kind of made a mental note of that they were on warfarin. And she was talking about just starting to talk about diet. She was like, oh, good news about my diet. I was like, oh yeah, what? I've never seen this patient before, so I don't know how it's going to be good news for me necessarily. She's like, good news on my diet. I'm like, oh, what's that? And she's like, I'm vegan now. I said, what's up? She's like, oh, I did nothing but the vegan diet, so I eat so many vegetables now. And I was like, how long did this happen? She's like, about a month ago. Oh crap. She had been on warfarin for a very long time, so was not getting INR checks. So sure enough, we checked her INR and it was not correct.
Yeah.
But it was just funny because she was so excited to tell me, and then I had to it's okay and we're gonna fix it, and then kind of burst the bubble a little bit.
Right.
Because please let us know before you do that.
Right. It's those sorts of things are the reason why warfarin's very unique. You have clinics kind of dedicated, clinic staff dedicated to warfarin. Patients will come to see their maybe clinician, maybe pharmacist, just for warfarin management because it has to be so closely monitored. We can get the INR right there and know what it is, and then talk to the patient. It's a conversation about lifestyle, if their INR is out of range, what's changed. I had a warfarin clinic rotation at the VA, and it was maybe in January or so. So for the first 2 weeks, everybody's INR was in the tank. This was in Aiken, South Carolina, because they had all had a bunch of collard greens over Christmas. And so that was the question to everybody is every time their INR was low, I'd be like, so do you have any collard greens over Christmas? They're like, yeah, I had my collards. And now the
is that really big in Aiken?
It's big in the South Carolina.
Okay.
Stuff. Yeah.
I got you. I don't
you like collard greens?
No. Do you? AJ?
Yeah, no, I don't know how to feel about that. Yeah, collard greens is a cultural staple.
My grandma used to make collard greens at all the holiday stuff.
We're cultured, and Mike,
add some salt on them. Collard greens are great.
I eat bagel bites for on Christmas Day.
Yeah, so
that's it.
Yeah, so diet and counseling, and then dosing adjustments from there. So
Let's mention reversal too, since we're on it. So
vitamin
K being the reversal option of choice, specifically available under the brand name Mephitin, oral and injectable versions or IV formulations. Basically, what we are looking at is when the INR is elevated to a certain extent or they're actively bleeding on warfarin, we would probably want to administer this. So it's the INR can be a little different though than we would expect, because 2 to 3 is our normal range. So if you have a patient that comes in and their INR is in 8.5, which we actually had just this week at my clinic, the tendency may be to everybody panic. But it's not that case. So there's kind of like a breakdown of 4 different groups basically. So INR that's above therapeutic range, but it's still less than 4.5 and not bleeding. We want to basically reduce or at least if nothing else skip a warfarin dose, monitor the INR, and then resume the warfarin when the INR is therapeutic again. Figure out what happened, maybe a diet change, like Cole was mentioning, or what have you. If the INR is 4.5 to 10, and again, there's no bleeding present, we would want to hold 1 to 2 doses of warfarin. So this is the range where we would actually absolutely hold and not just dose reduce. And then we would resume a lower dose of warfarin when the INR was therapeutic range again. We do not have to give vitamin K unless they need surgery or are actively bleeding. And then when the INR is above 10, that is when we're holding warfarin and we're giving 2.5 to 5 milligrams orally of that mephitin. And then we're starting a lower dose of warfarin once that INR is therapeutic again. Where that is different is if they are having a major bleed. Let's say they have an active GI bleed, their hemoglobin's tanking. We are going to obviously hold the warfarin, but also giving the vitamin K usually by slow IV infusion, and then also doing a 4-factor prothrombin complex, which is usually suggested over fresh frozen plasma in that kind of situation. But IV formulation in that case, so it's more of an emergency standpoint. But the INR change, as long as they're not bleeding, that's the big thing. So assessing hemoglobin levels and whatnot, but as long as they're not bleeding, we would wait until all the way up to 10 before actually giving oral vitamin K. So I think that's way higher than people anticipate.
It's pretty high. I think if I saw that, I'd be concerned.
I am. Like I said, we had an 8.5 this week, and it was like, oh no! It was actually one of my old PA students that was like, everyone relax. I was like, yes.
Dr. Vino told me, don't freak out until after 10.
Don't freak out until after 10. You mentioned a lot of the interactions already, right?
I only mentioned specifically amiodarone, so if you want to touch on some specific ones.
Basically, and we won't go through all these because there's so many, but with warfarin, it is a substrate for 2C9, and then it's a minor substrate for CYP1A2, 2C19, and 3A4. And it's also an inhibitor of 2C9 and a weak inhibitor of 2C19. And so, the anticoagulant, the anti-epileptics, anticonvulsants, especially our old school ones like carbamazepine, phenobar, phenytoin, are things that we think of with like 2C9. And then like Cole had mentioned amiodarone, as well as like the fluconazole, like we talked about with the apixaban. That's also a worry here from an oral standpoint. And then Bactrim is another one. They can interact with 2C9 and interact with warfarin specifically.
Yep.
The other thing to be aware of that I feel like is more prevalent now than it was in the past is looking for patients that are on herbal supplements that are not going to be like a direct, interaction from like a SIP standpoint. Because we do know that things like St. John's wort and things like that will interact from a SIP standpoint. But there's also a lot of herbal supplements that can just overall increase bleeding risk, whether it be they affect platelet aggregation or what have you. And so when you're on an anticoagulant, anything that can increase bleed risk, we want to avoid. But just to kind of throw out some herbal products that we got to be aware of. I always think of the G's, so like garlic, ginger, ginkgo, even ginseng to some extent, can all increase bleed risk. And I think a lot of those tend to deal with platelet aggregation and whatnot, but if they're already on an anticoagulant, that can be a problem. Turmeric, even like fenugreek can be an issue. Evening primrose can be a problem. And so those are things just to be aware of and make sure that we're checking, patients for over-the-counter use.
Cannabis as well.
Cannabis can. Oh, yeah, that's true. That is true. I forgot about that. So as medicinal cannabis becomes more prevalently used, that's another one that is going to be needing to be watched out for.
Is it a leafy green?
I guess depending on who you ask.
Does it act the same way if you smoke it or you eat the? Maybe it's not so leafy once it gets to that point.
Yeah. I think there's a SIP interaction too, right?
Yeah,
I believe
2C9.
Maybe. Well, that would make sense. That is
Smoke.
one. Yeah.
Like cigarettes.
Yeah.
Anything else on warfarin?
I don't think so. I mean, I'm sure there's plenty, but
there's a bunch.
Yeah.
I just didn't know if you had anything specific.
Yeah.
I did want to mention before we finish that there is a investigational drug out there that is a factor 11 inhibitor, specifically a factor 11A inhibitor in development. It's called asundexian, specifically used for Afib. So in some of the studies that are working on getting it approved, there were 753 participants with Afib, older patients, mean age of 74 years old, that were assigned to receive either 2 doses of this, asundexian, put up against apixaban, 5 milligrams twice a day. The rates of bleed were similar or lower in the investigational arm, asundexian, and there were no major bleeding, and clinically relevant non-major bleeding occurred in a low percentage of patients. A lower percentage of patients, I don't know if that's statistically significant compared to apixaban. So that was over 12 weeks, and I don't know if this was phase 2 or phase 3 or whatnot, but yeah, so that was from a few months ago. So that might be a new one on the block somewhere down the road.
Factor 11.
Factor 11A.
Didn't even know there was such a thing.
That's what it's telling me here. So
That's cool.
unless it's making it up to date.
Up to Date is known to make up stuff. They,
Well,
they throw in a couple
This is like in a big
satire articles.
Oh, yeah, you see a lot of up to date on.
That's not true.
A lot of up to date on Conan. You know, they pull it out on.
They did it
on
again.
those late night.
Factor 11
Yeah.
inhibitors.
Them up to date and the Onion. Those are the two.
That would be ridiculous. That would not be the place. I guess let's talk real quick about unfractionated heparin, just since we've mentioned it a couple times. But this is unique in that it is basically potentiating the action of anti-thrombin 3, which is another one of our very prominent natural anticoagulants, which is going to inactivate thrombin and factor 10 and preventing that conversion of fibrinogen to fibrin. So this can be used when in certain situations, whether it be for treatment or prophylaxis, depending on the indication. A lot of times during pregnancy is when you'll see this. So, sometimes if patients have an active malignancy that requires anticoagulation, heparin or low molecular weight heparin even more so was kind of the go-to agent. Now they're starting to move towards DOACs in that patient group, but you may still see that being utilized. The big thing to pay attention to with unfractionated heparin or low molecular weight heparin, like enoxaparin, would be the risk of heparin-induced thrombocytopenia, which Cole had mentioned, but that's what is abbreviated as HIT. And basically what happens is platelet factor 4 is released, and that's one of the things that is signaling other platelets to start that aggregation process. The problem is platelet factor 4 binds with very high affinity to heparin. And so some individuals can develop these antibodies to the platelet factor 4 heparin complex that forms. And so any platelet that contains this complex will then be targeted by our splenic macrophages. And so they have something called the 4T score that you can kind of estimate the likelihood of a patient developing HIT. But once the patient does, if they do develop that thrombocytopenia, it's important to no longer utilize unfractionated heparin or low molecular weight heparin, and that's where that agatroban and bivalirudin can also come into play. So just kind of wanted to make sure we mention that because I think that that's an important piece.
Yeah,
if I do say so myself.
Comes up a lot, and obviously that is an injection. And if patients are using an outpatient for pregnancy, they would have to inject themselves, which a lot of people have bad memories of having to do that for a period of time. That I talk to because I deal with injections a lot. They're like, oh yeah, I've done the heparin injections before and whatnot. And I'm like, oh, this isn't like that. Don't worry.
Yeah, I feel like that's a pretty mild injection.
Yeah, it's not too bad.
Yeah,
but nobody likes seeing the needle and
I
all
love
that
it.
stuff. I'm sure you do.
I just love giving myself an injection for no reason.
Speaking of steroids.
Yeah, no, not that kind. That would hurt. No, not that. That's too big of a needle. AJ'd have to give me that.
AJ would love
No
it.
comment.
He'd get the biggest needle possible.
Yeah, he'd be like, all right, 18 gauge it is. Like, no, that looks like a sword. What else? Anything else with anti-coag?
No,
I know there's probably so much more we could go over, but
an interesting overview. We've done specific episodes on VTE and on ACS and on Afib, so this was more of a hitting all the drugs thing. I liked it.
we warned you ahead of time.
I told you exactly what you were going to get. No refunds.
So make sure you guys check out the link in the show notes. That'll take you again to the freece.com's website. And if you're an unlimited member, then use the code BLOOD, all caps, and that will unlock the post-activity tests for you to ace with ease, and then you'll get your 1 hour continuing aid credit. So thanks to them again. AJ, a word from our sponsors.
Yeah, pearl of the day. I almost forgot. So the pearl of the day today would be the anticoagulant common reversal agents table that they've got nicely condensed there for you on the website. But you have to be a paying member to get access to this website. So that's the next step. And we've been given free pearls over the last couple of episodes. You're gonna have to commit after this one.
I would say it's probably worth it. Pearls is a very reasonably priced app, in my humble opinion.
PYRLS, Pearls.
Yep,
Good place to go.
Core Consult RX. You'll get a nice welcoming page that says, welcome friends of Core Consult RX. I love it. Sometimes I go to it just so I can feel cool.
I have friends.
But yes, thank you very much to Pearls, as always, for sponsoring the podcast, and they've been awesome for us. So make sure you support those that support us. We appreciate it. If you want more like lecture style content, as we've mentioned before, check out the Patreon, patreon.com/coreconsultrx. You get access to all the PowerPoint slides and lectures that I've recorded. That is basically the content that I utilize for my pharmacology, pharmacotherapy classes for my PA students. And it's a lot more boring, but if you like that kind of thing, that's available for you. And then if you have any questions for us, reach us at the emails in the show notes. You can text us at the number that's in the show notes. You can reach us on any of the social media platforms. Some way, shape, or form, you can get us, most likely. Now, how quickly we respond is going to depend week to week. We have several emails in our that we have to get to at some point, so we're splitting those up. But I promise it's not because we're not trying to talk to you. We definitely will try to get back to everybody at some point. But sometimes we get busy. Every once in a while. Anyways, thank you guys so much for listening. Thank you, Free CE. Thank you, Pearls. We'll see you guys in the next episode. Have a great one.